Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. In this presentation we're going to review the acute coronary syndromes and heart failure. Now, atherosclerosis is the process where athero, fat, cholesterol, sclerosis, hardening and narrowing. It's a buildup of cholesterol plaque in the walls of the arteries, which essentially and eventually will cause obstruction to blood flow. The plaques, however, can be stable or unstable, but if they rupture, they may cause an acute occlusion of the artery by the immediate formation of a thrombus, a clot. Atherosclerosis often has no symptoms until the plaque ruptures or there's a build-up which is severe enough to have blocked the coronary artery. So as an overview, an acute coronary syndrome is just a term used to describe a range of conditions associated with sudden reduced blood flow to the heart. And one such condition is a heart attack, which technically is a myocardial infarction. And a myocardial infarction is when cell death results in damaged or destroys heart tissue, necrosis. However, even when acute coronary syndromes cause no cell death, there is reduced blood flow and there's a sign of a high risk for a heart attack. Acute coronary syndromes often cause severe chest pain, or better terminology would be discomfort. And it is a medical emergency that requires prompt diagnosis and care. And the goal of treatment, as with all things, are to reduce or prevent further destruction of whatever the problem is. So in this case, it's improving blood flow and treating complications to prevent future problems. So, when we look at the acute coronary syndromes, what's the pathophysiology? And they all share a common pathophysiology, which is atherosclerosis, which leads to arteriosclerosis. Now, the three R in the acute coronary syndromes pattern are you've got non-ST segment elevation myocardial infarction, you've got ST segment elevation myocardial infarction, and you've got unstable angina. They're typically the three that are involved in this process, called the acute coronary syndromes. And as you can see there in the diagram, you've got a coronary angiogram, which is demonstrating an acute obstruction, 100% by the look of it, which would result in ST segment elevation myocardial infarction in most cases. So what are some of the risk factors for an acute coronary syndrome? The risk factors can either be modifiable or non-modifiable. Modifiable means that you can do something about it. Non-modifiable means that you cannot. So some of the risk factors include aging, hypertension, hypercholesterolemia, smoking cigarettes, a sedentary lifestyle where you have a lack of physical activity, the wrong diet, high in cholesterol, being obese or overweight, having diabetes mellitus, having a family genetic history of heart disorders or cardiovascular disorders such as stroke, also having a family history of high blood pressure, maybe even preeclampsia and eclampsia during pregnancy, and diabetes. Also, I've included there the COVID-19 infection, even though that really probably isn't a risk factor of an acute coronary syndrome. However, if you have other comorbidities, such as heart problems, respiratory problems, kidney problems, gastrointestinal problems, then possibly an influenza type of infection such as COVID-19 may have a contributing factor. So as we mentioned previously, the classification for acute coronary syndromes is unstable angina, non-STEMI, or STEMI. And that's important to note that, certainly from a medical perspective, because the treatment will depend on what has been diagnosed as what specific classification of the acute coronary syndrome it is. Now, when we look at unstable angina, unstable angina. Angina is Latin for strangling. And if it's angina pectoris, which it is, then this is a strangling sensation in the chest. And unstable means potentially problematic. So unstable angina is a clinical syndrome which is typically located between stable and exertional angina, or getting worse angina called crescendo, and eventually myocardial infarction. And this includes patients with severe or accelerated crescendo angina of new onset on patients with chest pain, which is provoked with minimal effort. And it can even occur with no effort whatsoever. Now you've got non-ST segment elevation myocardial infarction, which essentially is a partial blockage of one or more coronary arteries, causing reduced blood flow to the heart muscle. And this will typically be identified on an ECG as ST depression. Look at the ST segment. It's depressed. It's below the isoelectric line. Look at the coronary vessel. There's a partial occlusion with a thrombus. And on the myocardium, if you were able to get a CT or an MRI or a PET, then possibly you might see this. ST segment elevation myocardial infarction means on the ECG, the ST segment is elevated. And typically this means you've probably got a total occlusion of the coronary artery, and the myocardium is indicating transmural ischemia, which if not corrected immediately, or certainly within a certain period of time, will result in infarction. So you've got certain zones, which I'm not going to go into any great detail, called the 3 I's. You've got ischemia, injury, and infarction. Ischemia is typically reversible, and it can be identified as non-ST segment elevation myocardial infarction. Injury, you've got some damage. But still, if treated early enough and effectively enough, there's some reversible tissue injury. And this will typically be associated with STEMI. Infarction, this is irreversible. And even though we don't call it a Q-wave myocardial infarction anymore, we just call it a myocardial infarction. Typically a Q-wave, a pathological Q-wave, will represent irreversible myocardial tissue injury. Here are some of the evolutionary changes that may typically occur. They don't always occur, but they may occur. First of all, you've got a normal QRST complex. With non-STEMI, you've got ST depression or T-wave inversion of more than 1 millimetre, and it can become deeper, 2, 3, which indicates the severity of the potential problem. STEMI, you've got ST elevation, typically more than 2 millimetres, 3, 4, 5, and eventually you get a pathological Q-wave, sometimes referred to as Q-wave myocardial infarction. Here's an example of a non-STEMI ST segment depression. The ECG at this present time is normal. Have a look, ST depression now. And you can see on the 12-lead ECG that you've got ST segment depression or non-ST segment elevation myocardial infarction in nearly every single lead, which means all the coronary arteries are being affected. Now you've got STEMI. There's the normal ECG, but this is ST segment elevation myocardial infarction as indicated now. There's the ST segment and there's elevation. And if you look at the ECG, you've got ST segment elevation in most of the leads, which is quite extensive. What are some of the clinical manifestations of acute coronary syndromes? As we mentioned previously, You can have chest pain or discomfort, which is often described as being aching, pressure, heaviness, tightness, burning, or atypically, it may be silent, absent. The pain typically, as you can see by the diagrams, can be in a number of different regions, but it can spread from the chest to the shoulders, the arms, the upper abdomen, the back, the neck, the jaw. It can be associated with nausea and vomiting, or indigestion, which we sometimes call heartburn in the lay community. It can be associated with shortness of breath or dyspnea. You can be associated with heavy sweating, feeling dizzy, lightheaded, even fainting, and unusual or unexplained fatigue. And obviously, you will be feeling apprehensive and restless, which some people refer to as a feeling of impending doom. Something bad they think is going to happen. And it probably does. When you look at those pictures that you can see there, with the fist, the fingers spread, touching the arm, the left arm in particular, the left chest, this is called Levine's sign. Levine sign, and it's a classic indicator that you probably have a heart problem. How do you diagnose it? Well, assessment and diagnostics relate to history and physical assessment. They're the important ones, because it's the history and the physical assessment that will lead the doctor or the cardiologist to ordering certain other investigations. And the investigations could include blood tests like cardiac markers, which include troponin T, I, CKMB, which is creatinine kinase myocardial band, and myoglobin. It can include an ECG or an EKG, depending on which country that you're in. And this is electrocardiography, and this may detect changes in the heart's electrical activity during an acute coronary syndrome attack. And this can demonstrate either a normal ECG, non-ST segment elevation myocardial infarction, or ST segment elevation myocardial infarction, or in the worst scenario, a Q-wave myocardial infarction. You've got other tests like stress testing or exercise tolerance testing, where the person is put onto a treadmill and they are meant to work. And it makes the heart work harder, and this can now result in identifying whether there's a cardiac problem. Then you've got echocardiography, which typically relates to now cardiomegaly or heart failure, which can recur as a consequence of now an acute coronary syndrome. Or maybe even the heart failure is causing issues that result in an acute coronary syndrome. But essentially, an echocardiogram is looking at how well the heart is pumping and how well the valves are working when the heart is pumping, and possibly even identifying whether there could be a thrombus within the heart. Then you've got the most definitive, the definitive diagnostic procedure is a coronary angiogram. And a coronary angiogram will definitely identify if there are any obstructions in the coronary arteries. Others can be computerized tomography, an angiogram, a cardiac magnetic resonance imaging tool. When it comes to the management of an acute coronary syndrome, well, it depends. Often, no, always, lifestyle modification changes are recommended. Compliance with medications ordered by your cardiologist. Possibly even now revascularization therapy as an outcome. But the important ones probably are going to be dealing with your potential risk factors, such as high blood pressure, high cholesterol levels, stopping cigarette smoking, a low-fat diet, a low-sodium diet, exercise and weight loss, in conjunction with now medications ordered, prescribed by your physician. What are some of the medications that might be included? Well, nitroglycerin is one, and nitroglycerin is a vasodilator which essentially relaxes blood vessels and improves blood flow. You've got beta blockers, which together with nitrates are usually the first choice in the treatment of angina and the acute coronary syndromes. And they're especially beneficial with patients who are required to perform exercise or have activity. And in the literature, the beta blockers have definitely demonstrated that there's an improvement with patients that have got acute coronary syndrome or are at risk of developing an acute coronary syndrome. And their primary purpose is to slow down the heart rate and reduce the blood pressure. Calcium channel blockers, similar. Okay, they reduce blood pressure, and some of them, like verapamil and diltiazem, can reduce the heart rate as well. Then you've got angiotensin converting enzyme inhibitors, and they have an effect now as blockers to ACE1 and angiotensin 2. Other medications to reduce potential problems to do with high cholesterol are your statins, and these essentially lower your low-density lipoprotein cholesterol, your LDL, your bad cholesterol. Other medications such as antiplatelet agents such as aspirin, clopidogrel, ticlitipine, they are the more common ones. But again, their ultimate objective is to prevent thrombi forming in your blood vessels that potentially are atherosclerotic. Revascularization procedures such as percutaneous coronary interventions and coronary artery bypass graft surgery. And PCI, percutaneous coronary interventions, are often preferred to surgery because it's less invasive. And usually PCI, percutaneous coronary interventions, are preferred when only one or two arteries are blocked. Coronary artery bypass graft surgery is highly effective for people who have got angina, unresponsive to other interventions in coronary artery disease. But coronary artery bypass graft surgery is a very invasive procedure, and it will typically involve patients that have got maybe triple vessel disease, right coronary artery, LAD, circumflex. What's the prognosis for acute coronary syndromes? Well, as long as you're compliant, possibly things will improve. As we said previously, you've got modifiable risk factors and you've got non-modifiable risk factors. Age is non-modifiable. Genetics is non-modifiable. Gender is non-modifiable. But you've got other modifiable factors like stop smoking, medication compliance. If you're a diabetic, take your insulin, lose weight, control your diet. They're the important things. Now let's move on to cardiac failure. Well, heart failure is a chronic progressive condition that affects pumping of the myocardium. And if it affects both ventricles, right and left, it's referred to as congestive heart failure. And again, essentially, the heart muscle doesn't pump blood as well as it should, so it fails to meet metabolic requirements. You've got lots of variations of heart failure: right heart failure, left heart failure, diastolic heart failure, systolic heart failure, both, congestive heart failure, and the list goes on. And even the acute coronary syndromes can result in heart failure. So what's an overview? Well, as we mentioned previously, heart failure occurs when the heart muscle doesn't pump blood as well as it should. And when this happens, blood often backs up and fluid can build up in the lungs, pulmonary edema, left heart failure, or in the body, except the lungs, which is right heart failure. And this can cause peripheral edema, jugular venous distension, hepatomegaly, splenomegaly, ascites in the abdomen. And certain cardiovascular conditions like coronary artery disease or hypertension gradually leave the heart weak or stiff, which means it cannot fill properly and it can't empty properly. Remember, diastole is to do with filling. Systole is to do with emptying. If the heart can't empty and fill properly, you've got a problem. And this results in decreased cardiac output to the tissues and organs, failure to meet metabolic requirements. What's the etiology? Well, I think we've sort of covered that. But again, let's go through the list again. Atherosclerosis, arteriosclerosis, the acute coronary syndromes, any cardiomyopathies, congenital heart disease, diabetes mellitus, hypertension, cardiac dysrhythmias or arrhythmias such as atrial fibrillation, acute kidney disease or chronic kidney disease, obesity and a sedentary lifestyle, smoking cigarettes, using recreational drugs, and sometimes chemotherapy agents, because chemotherapy agents, radiation, affect good cells as well as bad cells. What are some of the clinical manifestations? Not too dissimilar to the acute coronary syndromes, but a little bit more. So with heart failure, typically you get orthopnea, which is shortness of breath that occurs when you are lying down, or activity where you are lying down. Fatigue, weakness, peripheral edema of the feet, ankles, legs. Tachycardia, which can be irregular because of premature ventricular complexes, maybe even as a result of atrial fibrillation, which is a common dysrhythmia associated in the elderly who have heart failure. Exercise intolerance, a persistent cough or wheezing with pink or white blood-tinged mucus, which is as a result of pulmonary edema. Ascites, right heart failure. Weight gain from fluid buildup, right heart failure. Nausea and lack of appetite, probably related to both, but more commonly right heart failure. Difficulty concentrating or decreased alertness, possibly because of decreased perfusion to the brain. Chest pain if the heart failure is caused by an acute coronary syndrome. How do you assess it? Again, history, physical assessment, ECG, cardiac catheterization, chest x-ray, echocardiogram, and sometimes even here, I won't say basic, but generic blood tests like a complete blood count, possibly to eliminate the diagnosis of anemia. Then you've got certain natriuretic peptides, which can be indicators of now heart failure. High levels of NT-proBNP mean that the ventricles are stressed. Low levels mean that the heart failure is stable. What are some of the classifications of now heart failure according to the New York Heart Association? Well, in the New York Heart Association, the heart failure classification is on functional limitations. So for example, class 1, the patient has heart failure, they're being treated for heart failure, but they have no limitations on physical activity. They can do everything without any distress. As you go through class 2, class 3, class 4, if we look at class 4, patients on all the required medications, they're doing everything the doctor says that they should be doing, but however, they have severe functional activities of daily living, physical limitations. And they're always there, even at rest. What are some of the types of heart failure? Well, as we mentioned previously, you've got right ventricular heart failure, where the right ventricle becomes bigger and too weak to pump blood to the lungs, or certainly not enough blood to the lungs. And as a consequence of that, with right heart failure, you get jugular venous distension, you get abdominal distension in the form of ascites, you'll now get hepatomegaly, splenomegaly, you'll now get peripheral edema in the feet, ankles, legs. Then you've got left heart failure, where the heart cannot empty properly. And as a consequence of that, blood backs up to the lungs and you get pulmonary edema. Then you can have a combination, which can be biventricular, right and left heart failure, which we often call congestive heart failure, so that you'll get the signs and symptoms or the clinical manifestations of all, which includes all the clinical manifestations of right heart failure and left heart failure. So what are some of the consequences? With right heart failure, as I mentioned, raised jugular venous pressure, hepatomegaly, splenomegaly, ascites, peripheral pitting edema. In the right heart, they are common. When we come to the left heart, you may or may not get a raised JVP, as indicated in the diagram, but if it's related to congestive, possibly you will. Certainly the heart will become bigger, cardiomegaly. You will develop pulmonary edema and pleural effusions. You may or may not get pitting edema, purely left heart failure. But typically, if you've got left heart failure, you will eventually become affected in the right ventricle as well, and you will end up possibly with now congestive heart failure. Here's an example of jugular venous distension, and this patient is sitting up at 90 degrees, high Fowler's position. There's an example of ascites. The abdomen is full of fluid. Possibly in this guy's situation with the umbilicus protruding as that, probably more than 2 litres of fluid in the abdomen. Then you've got pitting edema in the lower limbs. Right ventricular cardiac failure. Left heart failure, well here you've got a congested heart and you've got alveolar edema. Look at the lungs, they're pretty white. White on a chest x-ray typically means tissue or fluid. The lungs should be black. And most of the lungs are white, which indicates fluid in the lungs, pulmonary edema. What's the medical management? I'm not going to spend too much time on it, but I'm following the American Heart Association heart failure classification, and typically there are stages. Stage A is referred to as pre-heart failure, and the management is basically what we said before. Get some exercise, walk every day, stop smoking, take your antihypertensives, restrict your fluids, don't have a high sodium diet, don't have a high cholesterol diet, avoid drinking alcohol or using recreational drugs, and follow the medications that the doctor, your cardiologist, has prescribed for you. Stage B, all the same interventions that you are implementing already in stage B are provided. And then other medications that may be included may be things like aldosterone antagonists or maintaining your insulin, possible surgery, possible percutaneous interventions. Possibly if you've got valve problems, corrective surgery. If you've got a congenital heart disorder, which has just been identified as an adult, then maybe you may have a correction of that procedure. Stage C, all the interventions for A and B stages are implemented. So you're already on a diuretic, but you're probably going to go onto another diuretic. You're already on sodium restriction, daily weight monitoring, fluid restriction, and other interventions. Stage D, you're in the final stage, which basically means you need a heart transplant. And if you can't get a heart transplant, you may be a candidate for ventricular assist devices to assist the left ventricle, the right ventricle, or both ventricles, called biventricular assist devices. And if they can't help you, then possibly now palliative or hospice care to make your final days more comfortable. When it comes to the nursing management, our role as nurses are to monitor the patient's vital signs, auscultate to detect increasing or decreasing heart failure, observe for jugular venous distension, edema, fluid overloading, which can be done now on daily ways, accurate intake and output monitoring, and making sure that the patient takes the medications that they have been prescribed by the physician. And it requires us as competent nurses to strictly adhere to the doctor's orders. We monitor the patient's vital signs. We may do arterial blood gas analysis. And we want to monitor whether the therapies are actually being effective. And we report any negative findings or any positive findings to our physician or the person that we escalate the information to. And basic care includes mouth, eye, skin, and pressure ulcer prevention, because these patients are typically quite ill. So let's review. What causes the development of atherosclerosis? Atherosclerosis is the buildup of cholesterol or plaque in the walls of the coronary arteries. What is meant by the term acute coronary syndrome? Acute is sudden. Coronary heart syndrome, a predictable pattern. And typically, the acute coronary syndromes are unstable angina, non-ST segment elevation myocardial infarction, ST segment elevation myocardial infarction. They are three types of conditions which are known as the acute coronary syndromes. What is unstable angina? Remember I said angina is Latin for strangling. Unstable is potentially problematic. So unstable angina is a clinical syndrome between stable and myocardial infarction. That's basically what it is. And typically with unstable angina, the patient gets discomfort in the chest, maybe radiation to the neck, left arm, fingers, and it doesn't respond to treatment. So if they stop whatever caused the problem, maybe exercise, they took their medications, they're given oxygen therapy, it doesn't respond. That is unstable angina. What is non-ST segment elevation myocardial infarction? Well, this is when you get ST depression as a result of a partial occlusion in the coronary artery. What is ST segment elevation myocardial infarction? Well, this is where you typically get ST elevation on the ECG as a consequence of coronary vessel total occlusion. And unless corrected very quickly, will lead to myocardial infarction, which is irreversible. What are the clinical manifestations of an acute coronary syndrome? Well, the acute manifestations are they're going to have a chest discomfort, which can be burning, aching, pressure, heaviness, tightness, squeezing, and more. And it can spread from anywhere to the chest, shoulders, arms, upper abdomen, back, neck, jaw, or it can actually be silent. It can be associated with nausea, vomiting, indigestion, shortness of breath, very heavy sweating, feeling lightheaded, unexplained fatigue, and a feeling of impending doom. You're very, very anxious and apprehensive because you think something bad is happening, and it is. What is heart failure then? Heart failure is now a condition where the heart isn't pumping properly. Heart failure can be acute, but typically it's a chronic progressive condition and ultimately affects the right and the left ventricle, which is referred to as congestive heart failure. And because the heart isn't pumping effectively, it fails to meet metabolic requirements. What causes the heart to fail? We said any of them, any of the acute coronary syndromes, which share a common pathophysiology, which is called atherosclerosis, congenital heart disease, cardiomyopathies, diabetes mellitus, hypertension, renal disorders, being obese, smoking cigarettes, taking illicit drugs like cocaine or any of those derivatives, and even here if you're getting therapy for oncology disorders, possibly even chemotherapy and radiation. What are 6 clinical manifestations associated with heart failure? Very, very similar to the acute coronary syndromes. So you can get shortness of breath, orthopnea, which is when you become short of breath lying down, fatigue, weakness, peripheral edema, rapid, irregular heartbeat, exercise intolerance, coughing up pink sputum as a result of pulmonary edema, ascites, weight gain, nausea and lack of appetite, difficulty concentrating, and chest pain. So remember, when it comes now to the sequential delivery of data when reviewing any disease process, remember definition, etiology, pathophysiology, how you diagnose it, which really is a result of now history and physical assessment, how do you manage it, which can be medical, nursing, pharmacological, even nutritional. I mean, if you have to lose weight to control your diabetes, which will have an effect on your heart and your cardiovascular system, it's a good thing. Be aware of the potential complications, prognosis, and rehabilitation. Well, that's the end of that session. Thanks again for attending. If you think these are of any benefit to you, please subscribe and recommend them to other colleagues, friends that you think may benefit from it. Till the next time, take care.